endocrine referrals to a pediatric endocrine clinic, and it's important for all of us as clinicians to monitor growth for these respective reasons. One, growth is the barometer for a child's well-being. So if everything is going on fine, then we can reassure the patient as well as the family of normalcy. However, if there is any abnormality in the growth pattern of the child, it tells us about underlying disease, and it can help us to diagnose it early and treat it early. So we look at it as a very important clinical symptom rather than a disease itself. What are the parameters that we clinically monitor in children who come with short stature? We know primarily when we see at the anthropometry, we measure the weight, height. Other parameters which are of importance in children are head circumference, weight for height, BMI, and arm span. It is also important to recognize whether there is disproportion in the child. This can be easily done by measuring the upper segment, lower segment ratio in the clinic setting itself, and it can give clues to underlying skeletal dysplasias. When should growth monitoring ideally be done? It should be done at each well baby clinic visit or vaccination visits. Thereafter, after 5 years of age, it should be a clinical practice to document growth on growth charts at least 6 monthly to yearly in all children till the growth is complete. How do we measure growth? We all know for children who are unable to stand straight, the younger ones, we use the infantometer. For the older children who can stand straight, we use the Harpenden stadiometer, and there is a specific position in which the height needs to be measured correctly. Now, when a child comes with short stature, there are 3 key questions that we need to answer. Is this child really short? Is this short stature physiologic, or is there underlying pathology going on? If this is pathologic, is it a primary bone problem, or is it a secondary short stature? Let us look at a case scenario. This is a 6-year-old boy who is referred for poor height gain. So mom is concerned that he's short compared to his peers. This baby is born with a good birth weight of 3.2 kilos and has had an uneventful perinatal course. He's developing normally and has a good scholastic performance. Generally, he is healthy, there are no systemic concerns, and he is proportionate on examination, and there are no dysmorphisms noted. His bone age is matching his chronological age. His bone age is 6 years and 4 months. Let us look at his growth chart. And then try to answer whether this child is short or not. So looking at the growth chart, this is a CDC growth chart which is blue, so used for boys from the age group of 2 years to 20 years. If you look at the plot lower down there, that is for the weight, sorry. Yeah, so if you look at the dot lower down, it's for the weight, and the dot on the upper side, those two are for the heights. Now, if you see the weight age and the height age, which we calculate by drawing horizontal lines from the child's current weight and height up to the 50th percentile line, and then dropping a vertical line downwards, that is coming as 4 years, 6 months. It simply means that at the age of 6 years, this child has a weight and height which is expected of a 4.5-year-old. Secondly, looking at the way he is growing, we fortunately have a previous plot, so we know that he is growing around 5 centimeters in a span of 1 year, which is his growth velocity. Look at the 3 lines on the right hand side. They are the mid-parental target height and mid-parental target range. If you track these two further forward up to 18 years of age, you will realize that he is growing within the mid-parental target height centiles. So now, do you think something is wrong with this child? Probably no. It is familial short stature. The child is genetically programmed to grow in this manner. So in such cases, all we need is reassurance and follow-up rather than subjecting the child to expensive tests. So what is short stature? As a height that is severely affected and below the first percentile or below 3 SDS of the mean for age, gender in a given population. These are the children who need immediate reference to a pediatric endocrinologist and immediate workup because likely cause is pathological in their case. The second scenario, growing short below the 5th percentile, However, the growth velocity is dropping. So you can see that there is flattening in the growth curve. This is again defined as short stature. Model of ICP during infancy, childhood, and puberty. So can you see it's so predictable? It's a complex process, yet it's very, very predictable, which helps us to understand any deviation from what is going on. During infancy, it is primarily nutrition and thyroid hormones that play an important role in presence of normal bone metabolism. During childhood, it is the growth hormone and thyroid hormone in addition to nutrition that is regulating the growth. Mind you, childhood is also a phase when there are a lot of changes occurring in the body proportion. So a baby who has upper segment to lower segment ratio of 1.7:1 is now changing the body proportions, and by the time he or she is 10 years of age, the upper segment lower segment ratio is reducing to 0.9:1 or 1:1. This is a very important clinical criterion for evaluating short stature. During puberty, there are sex hormones which become the major determinants, the estrogen and progesterone, and they help in the growth plate growing, or the axial growth of the bone. As much as 20% of the adult height, which is approximately 25 centimeters in boys and 20 centimeters in girls, can be gained during these 3 to 4 years of puberty. There are other factors which affect growth in addition to the ones that we have just discussed, such as ethnicity, seasonal factors, psychosocial deprivement, secular trends occurring, as well as environmental factors. This is a diagram which is showing endocrine regulators of growth. It looks intimidating, but it simply shows the hypothalamo-pituitary growth hormone axis and its effects on the growth plate or on the bone on the right side. So if you see, the hypothalamus exerts positive or negative signals on the pituitary for growth hormone secretion. Conditions like fasting, sleep, hypoglycemia, exercise, puberty, and estrogen are important to augment this positive effect on the growth hormone. It also secretes somatostatin, which exerts a negative tone on the pituitary for growth hormone secretions. And the factors that accentuate this negative tone are hyperglycemia, we've seen that in our diabetic children, hypothyroidism, steroid intake, glucocorticoid excess, obesity, and emotional deprivation as well. Now, pituitary also, growth hormone secretion by pituitary is also under the control of ghrelin, which is secreted centrally by the hypothalamus or locally by the gastric neuroendocrinal cells. This growth hormone is found in its bind form or bound form to proteins or in the free form. It ultimately binds on to the growth hormone receptor and causes secretion of IGF-1 or the IGFs from the liver, and ultimately affects on the growth plate, which you can see on the right side. And it has effect on the resting zone and the hypertrophic zone within the bone growth plate, causing osteochondrogenesis and hence increasing the length of the axial bones. Sex steroid and thyroxine augment this effect, especially during puberty. Glucocorticoids have a negative effect at the end plate as well. So now can you understand that if anything goes wrong at any of these checkpoints, that can become a cause for short stature. For example, if there is an intracellular or supracellular mass sitting there in the region of hypothalamus and pituitary, it can affect the growth hormone secretion. From then on, if there is a systemic disorder which is affecting the liver, which is also having some inflammatory markers that affecting the bone growth plate, it can result in short stature. And then the third variety, where the bone itself has a problem, an inherent genetic problem such as skeletal dysplasias, that can again result in short stature. Moving on, so this is a simple classification of growth disorders, although the chart may look quite intimidating. However, it can be simply divided into physiological variant, which is a genetic variant. You could call it a normal variant, where not necessarily much treatment is indicated. Pathological, where definitely identification and early treatment can make a difference both for the disease and for the child's height. These disorders are 80% of the times in the category of chronic malnutrition or chronic systemic diseases. Rarer problems like endocrine causes such as hypothyroidism, growth hormone or multiple pituitary hormone deficiency, pseudo-hypoparathyroidism, Cushing's disease or syndrome, we must also be aware of these. There is another set of children who are small for gestation age and they fail to catch up by the age of 2 to 4 years. This is a tricky set of children we must recognize because they also have some androgen excess going on, and these are the ones who end up in early puberty and have short final adult height. These children, if caught early and is started on growth hormone therapy, can do fairly well in terms of adult height. There are syndromic variants, iatrogenic disorders such as surgery, irradiation, medications like we discussed, steroids, and psychosocial deprivation which can affect height. If we follow a systematic approach, it then becomes simple in a clinic setting to diagnose a child with short stature. We cannot emphasize more on history, anthropometry, plotting the growth chart, a thorough clinical examination, and pubertal staging in a child. Once we have confirmed that there is dysmorphism present, we look at specific signs or symptoms of syndromes such as Turner's, Downs, Noonan's, etc., and then order definitive tests such as karyotype or genetic testing. If there is dysmorphism, in addition there is disproportion with the upper segment lower segment ratio being abnormal, we would rather order a skeletal survey and look whether appendicular or axial system is now affected, and then do the specific genetic testing. Suppose there is no dysmorphism, we then follow a simple algorithm of looking at the child's weight age and comparing it with the height age. Now, if look at the third column there, where the child's weight age is more than the height age, which means he is more plump than he is short, or she is more plump than she is short. In such a case, if we have a severe short stature and delayed bone age, more than 2 years compared to the chronological age, we are looking at a likelihood of endocrine disorders. Other than that, if the weight age is more affected and less, then we are looking at malnutrition as a cause of chronic disease. Accordingly, we send our investigations and treat. I have a few case scenarios. Now I'll run through them because I have very little time left. This is a 5-year-old female. Can you note the lymphedema on the hands and feet? Can anybody guess the diagnosis? This child has increased knuckle translucency. I also tell you that she has clinical features of webbing of neck, low set ears, broad shield. Definitely she is a case of Turner's syndrome. So if you look at her growth chart, she is at 4 years, short for the population, short for the mid-parental centiles. We went ahead and did the karyotype. We found it to be 45X, confirming Turner's syndrome. Started this child on growth therapy at around 4 years. Subsequently, because we know Turner's is more prone to get autoimmune disorders, we checked thyroid and TSH was raised. She received thyroxine. We did pubertal induction at around 12 years of age, and she received growth hormone therapy until 14 years, until her growth was completed. Yeah. So that is the importance of recognizing these clinical clues, especially in cases like hypothyroidism, where along with the short stature, mentation can be affected and it can be reversible. So treating them early is very, very important. These are the first line investigations, and you can see the top of the list is mainly aimed at systemic disorders because that is the crux of the problem in majority of the cases. One thing I want to highlight with this slide is that for any child with unexplained short stature, please do a karyotype because the incidence can be as high as 1 in 2000 to 1 in 2500 live birth. Bone age gives us a lot of clue about endocrine problems. I'm going to skip through case 3 because my colleague is going to discuss that in the next session of delayed puberty. This is a simple case of constitutional delay in growth and puberty, as you can see in the growth chart. What I wanted to tell you is random growth hormone test, which came back as normal in this child, should not have been done in the first place because it carries no role. We know growth hormone is secreted in pulses and not uniformly. The third thing, he went on to have a stimulation test at 13 years of age. This was not primed and it gave us a falsely low test. So please remember, all peripubertal children with short stature, if you're doing a growth or stimulation test, do it with priming with either estrogen or testosterone. You can use estrogen in both girls and boys. So we did a prime GH testing, which was fantastic, and the father gave us a history of having delayed growth in himself. This was simple constitutional delay in growth and puberty. These children, if psychologically affected, only then may require sex steroids, or if the pubertal delay is beyond 15 years of age. And he grew this way within the mid-parental target centiles at 18 years. Bone age assessment is a very, very important tool when you're managing children with short stature. One, it can tell you about if it is advanced, delayed, or appropriate. It can tell you about what's going on in the body, as it is the true indicator of skeletal or bodily maturity. It's done in various methods. I personally use the Tanner-Whitehouse staging. We heard a talk on AI. So there are apps available which can give you Tanner-Whitehouse staging within 5 minutes in clinic. And there is Bone Expert available, which is quite objective software and gives you a very accurate result. So in case the bone age is severely affected, think about endocrine disorders. If the bone age is not affected, check for disproportion and think about syndromic varieties. This is a fourth case. This is very important, and I want all of us to not miss such children. Look at this girl. She was growing at the 50th percentile all along, and suddenly she stops growing. In the last 3 years, if you see, the growth centile has fallen totally off the chart, and she's now below the 3rd percentile for her age. So what's going on here? Definitely something grave is underlying this cause, this flattening of the growth curve. If you see the small red triangle, that's the bone age of this child. So that means at 9 years of age, her bone age is delayed by 4 years. So something is definitely going wrong. In the next 6 months when we examined her, she also was in early puberty and her breast staging was stage 2. For this girl, we did do a complete systemic examination, nothing revealed on clinical examination. However, with this grade of short stature, we tested her and we found that the thyroid hormone was low, and the growth hormone stimulation testing showed that it was severely affected. So this was a case of growth hormone deficiency. And guess the underlying cause? MRI showed multiple pituitary hormone deficiency secondary to an intracranial lesion, which was craniopharyngioma. She had to undergo neurosurgery and subsequently was put on growth hormone, etc. So please don't disregard the growth charts. They can give you important clues for life-threatening disorders such as these. These are the indicators for growth hormone deficiency. I know my time is up. I just have 2 more slides and I will finish it soon. Growth hormone testing. Insulin tolerance test is not done for less than 2 years. We mostly do clonidine or arginine stimulation testing. In centers of experience above 2 years, we do the insulin tolerance testing. So these are the indicators of growth hormone therapy, and these are the licensed indications. The growth is at the dose of the growth hormone is at the lower end for pituitary hormone deficiency, and at a higher end for Turner syndrome and the likes of SGA and syndromic variants. It has been going on for more than 50 years now, this growth hormone therapy, and we are using recombinant growth hormones. We know that when started at a younger age, when given for a longer duration, and when the baseline height and growth velocity in the first year is good, We have enhanced adult height, and we should aim at achieving this in all our short children. We must be aware of the side effects of growth hormone and inform the parents about them. And one very important thing in addition to monitoring is transitioning all our children to adult care. They have been in chronic care of endocrine departments in pediatrics for years and years, and suddenly we give them a note saying now go to the adult department. They can be overwhelmed. It's good practice to start having transition clinics, explain them, do the tests that are necessary before you transition them on to the adult clinic to gain their confidence and for them to now be compliant with the medications when they move on. Thank you. These are the take-home messages. Growth charts, use all of you, please use growth charts. Every child should have one. And then I have mentioned all the others. I want to show you an interesting picture. This is an Australian comedian, very celebrated. Dave is huge. So does height matter? I think it surely does. You see him standing on his toes, isn't it? Thank you.
Thank you so much, Dr. Madhura. I know there are many adults who are very short and they are thinking, what can be done now? But it's too late, my dear. So the next, we'll not take questions now. The next speaker is Dr. Joyce Mbogo. She is a lecturer at she's a member of PESC and lecturer at the Kenyatta University. Welcome, Joyce.
Thank you, Dr. Anjum, for the kind presentation. Thank you for Kdsg for including us children, even if you are adults, to your conference. We did indeed think very deeply about what kind of topics you're going to present to you, because some of these topics are seen both in pediatrics and also seen in adults in the physician's offices. So please listen to them and know that we want to co-share, co-manage these cases. So today we'll be talking about an approach to delayed puberty. This is going to be my outline. Again, we'll have a case presentation that will help us guide us as we walk through delayed puberty. So as a case presentation, a 14-year-old male, he actually came in with short stature. And the reason why he came in because of short stature is because he's the shortest in his class for the last 3 years. He's very sporty. Was in a basketball team, and somehow this time he was being benched because one, they found him to be too short, can't do those 3-point shoots as he was wanted, and he wasn't bulky enough. So that really made, unfortunately, the coach keep benching him for competition, yet he really wanted to take part in the sports activities. Birth history was non-significant, didn't have any past medical history. Family history, as you go ahead, he saw that our father actually was a delayed bloomer. And what he said is that he caught up with his age mates in college. And so they made fun of him in high school, and all of a sudden when they're in college, it's like, yeah, you see, I'm the same height with you now, right? So all his bullies were more or less the same height by the time they actually reached college. Mother attained menarche at 13 years, and brother currently, who is 12 years, was the same height as the patient. So he was really frustrated. My younger brother, who is 3 years younger than me, has the same height as me, and I'm not doing what I really love, which is actually basketball. So as that in the background in terms of a case presentation, let's define what delayed puberty is. So delayed puberty is the absence of signs of sexual maturity by the age of more than 2 or minus 2 SDS for the mean of the population. Now I need to take you guys back because I just want to educate you that puberty starts at 8 years for girls, normal puberty, 9 years for boys. Can I start that again? 8 years for what? 9 years for? Please, because I think we kind of get so frustrated when they actually come in with breast development at 8 years, yeah? So for the female, how do you define delayed puberty? The absence of breast buds at 13 years. And if you do not progress to the final puberty by 5 years, or you have not had menarche by 16 years. What about males? Males is the lack of increase of testicular volume from 3 to 4 by 14 years, or you have not reached your adult testicular volume by 5 years when you started it. Okay? We are together until there? Because it is so important if you understand what normal puberty starts and what delayed puberty is, so that you can know, is this child delayed when they come to see you? All right, so since I've actually talked about breast bud development, and I've talked about testicular volume, this is the Turner staging. Anything that is above 1 is prepubertal. So in other words, if the testicular volume is 3 cc's and you are 14 years as a boy, that means you have delayed puberty. If you do not have any breast bud development in a female and you're 13 years, you have what? Delayed puberty. And then if you go back down, if you haven't progressed from number 2 to number 5 by 5 years, you have what? Delayed puberty. And this should actually guide you in terms of that. All right? Okay, so moving on, what are the equipment that we use? So we have what you call an oculometer. These are the ones that help us to be able to assess what testicular volume is. You can see it has 1, 2, 3, 4. So we want you to see if the testicular volume has moved from 3 to 4. If it has moved to 4 by 14 years, that's not delayed puberty, right? If it is 3 and below, you have delayed puberty in males. You should also do penile length stretch. However, you need a chaperone, you are a female. And anyway, even if you are a male, please make sure that a healthcare, the guardians are there and you seek permission from 2 people, from the guardian and from the patient, right? Please, before you actually do these examinations. So, as an introduction, what's the incidence of delayed puberty? Now, in 2012, there was a New England review that actually showed delayed puberty was quite frequent. And what this author did is that he divided them into hypertrophic hypogonadism, divided into permanent hypogonadotropic hypogonadism. That means that the issue is in the brain, and functional hypogonadotropic hypogonadism, which basically meant that you have other chronic illnesses that are causing you not to go into puberty. Now, what was interesting, can you see that the functional hypogonadotropic hypogonadism was the leading cause of what? Delayed puberty for that time. Now, let's go back to 2022. Sylvia et al. Also did another review, and this time he broke it down a little bit more, where you had the hypogonadotropic hypogonadism, where you have an issue with the gonads, and then you have the permanent hypogonadotropic hypogonadism, where you have an issue with the brain, whether it's a hypothalamus or the pituitary. Then you have the constitutional delay of growth and puberty, and finally the functional. So number 1, what was more common? The constitutional delay of puberty and growth. And you can see males were more affected than females. Then secondly was a functional hypogonadotropic hypogonadism, which really meant that it had nothing to do with the hormones in terms of the hypothalamus pituitary axis, but had the other chronic issues were actually causing this child not to go into puberty. So for you to understand delayed puberty, I think it's so important to understand how it actually starts. So remember, when you're born, after 1 week, the hypothalamus pituitary gonadal axis is actually open, and so it actually works for boys for 6 months, and then it quiets down and goes to sleep. For girls, up till 2 years, it goes to sleep, right? Around 8 years for girls, 9 years for boys, it restarts. So there's a neuroendocrine system that actually restarts it, and that includes the kisspeptin, that includes the neurohydroformin, that includes the neurokinin B. All this restarts the regulation of the production of the GnRH that is released from the hypothalamus. So when does it actually start? Usually it starts releasing at night. So they have like this pulsatile releases of GnRH at night. The GnRH goes into your pituitary, anterior pituitary. At that place, what is released? LH and FSH. LH and FSH, and then go into your end organs, which for a girl is an ovary. In the ovary, what ends up happening? Estrogen is released. Estrogen is released, you have breast what? Development. And that's why it's so important to check for breast what? Development, because that's a real sign of puberty progression. What about the boys? Goes down all the way to the testes. Then you have the LH and FSH. You end up having what? Leydig cells producing testosterone. You have FSH having Sertoli cells actually doing spermatogenesis. So what happens to the testes? The size increases to 4. So that's why you actually know that is what? Real puberty. okay? And then thereafter, you start having all these other developments that happen. So if you have any abnormality in that whole axis, then you have a chance of actually having what? Delayed puberty. So how do you start evaluating them? So you have an initial evaluation. History is so important. Then you go to your physical exam before you even start going into investigations. So let's talk about the history. What are you interested in? Because you do know now the second most common cause of delayed puberty is because of functional hypogonadotropic hypogonadism. You also need to start thinking of other conditions that can actually cause that. So you ask about abdominal pain, constipation, diarrhea, hematochezia, if you're thinking about inflammatory bowel disease. Then you talk about weight gain, constipation, if you think this child could actually be having what? Hypothyroidism. Or the opposite of hyperthyroidism, where you're actually having this child is eating a lot, losing weight, and also having tremors. What about the girls, which is very, very common? Girls who actually eat so well, but somehow seem to always go to the bathroom 30 minutes after eating and do what? Vomit, seem to be very slender. Anorexia nervosa has been known to actually cause delayed puberty. All right? What about other things? You start going back to that family history, the birth history, asking yourself, is there anything that happened then? Did they actually have undescended testes? Did they have any hypoglycemia at birth? Because that would be pointing out towards growth hormone deficiency or multiple pituitary hormone diseases, deficiency. So basically, you start through your history, it will actually give you a good sign of what you're going on. But remember, don't forget the family history, because that will also guide you to think about if it is the most common cause of delayed puberty, which is constitutional growth and pubertal delay. So moving on after that, what do you go to? You actually go to the physical examination. In a physical examination, I think my colleague has really emphasized we need a growth chart. So now, unfortunately or fortunately, in our setting, kids are transitioned at 14 years, right? We have and we have a whole combination of people here. So we have nurses here. So please, nurses, please, pediatricians, please, physicians, please monitor growth, because you'll be able to detect these things pretty early. Because if you have a low growth velocity, that's also going to tell you that. Okay, if you have small testes, you have an absence of smell, you have teeth that are actually losing, all those physical signs will actually tell you that, at least point towards why you'd actually be having delayed puberty. So back to our case, height at the time the patient presented was 145, and when I did SDS was minus 2.83. Now when I did the mid-parental height, I had taken the mother's height. This is a biological mother, taken the father's height. This is a biological father, I'm emphasizing that, and calculated what the target height is actually going to be. In terms of standard deviation, it was minus 2.2 to plus 1.21. But this boy is growing at minus 2.83. So he's definitely growing much shorter than he should actually be growing for his family genetic potential. When we did the physical examination, looking for other signs that could guide us towards what could be causing this delayed puberty, they were all negative. No high-arched palate, no midline facial deficiencies, abdomen was soft, non-tender, didn't actually have any fecal masses. Skin was actually soft, it actually did not have any dry skin. And when we went to the genitalia, so breast was standard 1. I think it's very important to know why I'm actually emphasizing on breast being standard 1. Pubic hair was standard 1, but pubic hair doesn't matter because pubic hair is because of another axis, which is the adrenarche. The adrenals are the ones that cause us to have pubic hair and axillary hair. But when you actually go into the testes were 3 cc's. And when we said when you're in real puberty, the testes should be above what? 4 cc's. So we knew this child was actually short and had not started puberty. So what investigation should it actually do? Now remember I told you initially when you start puberty, GnRH is released at night. So that's why, and in pulsatile forms before it actually starts being released throughout the day. So blood should always be drawn before 8 a.m. I need to emphasize, don't do it at lunchtime. Don't do it in the afternoon. Blood should be drawn before what? 8 a.m. So you go back again, do the gonadotropins, you do the sex steroids. A bone age is very important, and if you do your physical examination and you see that maybe there are other things that could make you think that they have hypothyroidism, go ahead and do TFTs. In the history, it tells you that maybe this child could have celiac disease. Go ahead and test, and I'm telling that because, sorry, I have called, is the fact that These tests are quite expensive. So by the time you're actually doing these tests, they need to be targeted. They should be guided by your history and your physical examination. Lastly but not least, in that slide, you'll actually see it on it's going to be on my right side. If you look at the sex steroids and the gonadotropins, they're actually staged according to Turner stages. So when you are interpreting your LH, your FSH, your estrogen, your testosterone, look at your physical exam and ask yourself, does that make sense? That's the difference in terms of pediatric endocrinology. Everything goes back to your Turner staging, goes back to your age of the patient. And so every time you're interpreting lab results, always go back. There are reference values that so that you can know whether you should be concerned or not. So if you go back to our patient, LH, FSH, they were low. But again, if I go to my physical examination, that's what you expect in Turner stage 1, right? Then you go to TSH, it was normal, free T4 was normal, so no thyroid disease, celiac screen was negative. When I do the IGF-1 and IGF-BP3, remember this boy was 14 years. But his IGF-1 and IGF-BP3 were actually normal for a 12-year-old. Took an X-ray of the left hand, read it. His chronological age is 14 years, and his bone age was 12 years, right? So basically, he had delayed bone age at that particular point. So what did we say? It was a diagnosis because of the history, because of the physical examination. Family history also guided us. We knew this child, we diagnosed this child as having constitutional delay of growth and puberty. Now, just to talk a little bit more about that, it's a normal variant of an otherwise normal healthy child. We think they, at the extreme 5%, that actually just start puberty much later. It's the most frequent form of delayed puberty. Classical signs, this is a child who's actually very healthy, was growing okay. Around 2 years of age, if you actually monitor their growth, you start seeing the height gradually going down to the 5th percentile. When you do a physical exam, it's within the normal range. They have a delayed puberty, and there's usually a family history of a late bloomer, whether it is the mother, the father, or the uncles. You'll actually get that family history that way. And then when you actually predict the adult height, when you do the bone age, you can actually see this child attains the final height for the family. Diagnosis is of exclusion. Treatment is actually self-limited, but however, if they're having psychosocial stresses that they cannot be able to wait anymore, we actually say, you know what, you can try and jumpstart the puberty if they cannot wait. But most of them will eventually go into puberty and eventually attain both the sexual maturity and their final adult height. So how do you treat it? For the boys, you can give testosterone, right? 50 milligrams, IM 3 times or 6 times, and then stop. By that time, the boy is going to puberty. For the girls, you can also use estrogen tablets also, or patches if available. So in conclusion, right, delayed puberty is a common condition, causes significant psychosocial stress especially in the boys. If you do a good if you do a good history, physical exam, family history, most of the time you'll actually have an idea of what's going on. If you can actually just monitor the growth, that will give you a good idea why this child is actually having delayed puberty. Constitutional growth and pubertal delay is the most common cause. Please discuss with your patient and with the family on what you're going to do in terms of investigation, and it actually is going to take a while, and treat appropriately depending on what's the cause of the delayed puberty. Thank you.
There'll be very many questions for you guys, but let me invite the third speaker. Yeah. She is Dr. Winnie Saumo, a member of PESC, works as a pediatric endocrinologist at Chuka Level 4 Hospital. Thank you.
Thank you, Dr. Anjum, for that introduction. I'll be taking you through approach to infants born to mothers with thyroid disorders. Do Do we have any gynae in the house? Any gynecologist? Okay. So I have no conflict of interest to declare. I'll take you through that outline, and in addition, I will do a case. So we start with a case, baby EM, who was born at term to a para 2+0 mom, and this baby weighed 2 kilos at term, meaning they had low birth weight, and also a UGR. There was no history of maternal illness in the mother that was reported, but mom said that she had great appetite during pregnancy. And all of us know that during pregnancy, most mothers say, ninakula sana. So most of the time, that one is usually not taken seriously. And the baby was noted to have proptosis and a tachycardia of 187 beats per minute. Can we all appreciate the proptosis from the picture? Okay. So in this facility, they were able to do thyroid function test at day 2, and the TSH for this baby was at 0.05 micro international units per ml, which was suppressed, and also the free T4 level was found to be high, and the free T3 was within normal. So I want you to have that case at the back of your mind as we proceed. So thyroid hormone is vital to fetal and neonatal neuro development. It is really important for brain development in babies. And the thyroid gland is the first endocrine organ to develop. We know that pregnancy increases demand for thyroid hormone and iodine requirements. And in utero, fetuses depend on transplacental transfer of maternal iodine and thyroxine, especially thyroxine until 16 weeks of gestation, when their hypothalamo-pituitary thyroidal axis matures. And maternal thyroid dysfunction will impact negatively on the fetus and the neonate. And newborn screening has allowed for early detection and treatment of thyroid disorders of the newborns. In our country, we are not currently doing neonatal newborn screening for thyroid disorders, but in the West, that is happening, and we hope we will be able to reach there. Because we know hypothyroidism can really cause mental disability in these babies. So I take you through the thyroid physiology. We know that thyroid hormone is usually the control is at the level of hypothalamus, where we have the TRH being produced, acting on the anterior pituitary to produce the TSH, which then acts on the TSH receptors on the thyroid gland to produce the T4. And then the T4 can be acted upon by the iodinases, the D3 to form reverse T3, and the D1 to cause to convert it to T3. Then the other diagram depicts what happens in utero. So we have the maternal side and the fetal side. So TSH usually placenta is impermeable to TSH. So there's usually no TSH crossing from the maternal side to the fetal side. TRH crosses, but it is usually in very small amounts, so it is usually very negligible. However, T4 is usually transplacentally transferred to the fetus, and usually that is usually through some transporters than the MCT transporters to the fetal side. And also iodine from the mother is also transferred to the fetus. And this is really important because during the first 16 weeks of life, babies depend on maternal thyroid hormone to survive, and also especially for the brain development. So this picture just depicts the changes in fetal, neonatal, TSH and T4, T3 levels over time. So you can see from around fetal TSH, T4, T3 begin around 12 weeks of gestation, and usually the levels are low, and with time they keep on increasing, especially the T4 and the TSH. And then what happens at birth? When babies are exposed to cold, you know, when the baby is born, there's that cry that we usually wait for. So at this point, because of the cold, the exposure to the cold, there is usually what we call a rapid surge of TSH in these babies. And this usually allows increase in the levels of thyroxine. And the TSH levels will fall and normalize over the first week of life. So so there's a surge, and then from day 3 going forward, the levels start normalizing. However, the thyroxine levels will remain elevated until approximately 4 weeks of life. So let's go through what are some of the maternal thyroid dysfunctions that can affect babies. So the leading cause of maternal thyroid dysfunction is autoimmune thyroid disease. And the most common is Hashimoto disease and Graves' disease. So maternal immunoglobulins usually cross the placenta from mid-gestation. And these are some of the immunoglobulins that can cross the placenta. The thyroperoxidase autoantibodies, the thyroid stimulating autoantibodies, and thyroid blocking receptor autoantibodies. So for hypothyroidism, we said the common is Hashimoto autoimmune thyroiditis. And also, the other cause would be any mom who has had a Graves' disease, that is hyperthyroidism, and they have been medically or surgically treated. And then we have a category of mothers who have congenital or primary hypothyroidism or central maternal hypothyroidism. Their babies are more likely to have hypothyroidism. So Hashimoto is the commonest, and it's because of the transfer of the autoantibodies, and usually these babies get what we call transient hypothyroidism. So it's usually there until the autoantibodies clear from the baby system. And then for the mothers who have congenital hypothyroidism, their babies may inherit the same problem if there's a genetic mutation in any of the pathways of the thyroid hormone formation. And then also transient hypothyroidism due to medication, especially for mothers who have been on carbimazole. Then also we know that iodine deficiency can cause hypothyroidism in the babies, because we've said that in utero there is usually iodine transfer from the mom to the baby, so that baby is able to form the thyroid hormone. And also the iodine excess also can lead to transient congenital hypothyroidism, and this is usually through inhibition of the TPO mediated uptake and organification of iodine, what we call the Wolff-Chaikoff effect. So what are the signs and symptoms of hypothyroidism in a newborn? So number one, these are babies who are usually postdatism. So the baby will be delivered after 42 weeks of gestation, and then most of the time they have macroglossia, they have large fontanelles, wide sutures, rough dry skin, and these are the babies, mothers will tell you that they haven't passed meconium for the first 24 hours, and they have chronic constipation. So I think I've talked about that. And then studies also have shown that mothers who have hypothyroidism, they usually have poor outcome. For example, preterm deliveries. These are mothers who will most likely go for CS deliveries, and also the APGAR score is usually poor. So what this means is that for the gynecologist, it's actually, and the adult endocrinologist, it is really good to really manage mothers who have thyroid disorders in pregnancy. And then the other impact of this hypothyroidism is that usually babies born to mothers with hypothyroidism, they have been shown to have IQ scores that are lower than controls. So what are the investigations that we do? So for hypothyroidism, so if it is primary hypothyroidism, they will have high TSH level and low free T4 level. And then the serum antithyroid antibodies might be positive. Treatment, we usually use levothyroxine 10 to 15 micrograms per kg per day, and usually the dose is titrated according to the levels of TSH. And then because most of these babies born to these mothers have transient hypothyroidism, we usually say that for you to consider treatment, the child should be symptomatic. And also, they have a biochemical evidence of hypothyroidism. So newborn screening is important, and there are different approaches that are employed across the world. Most of the countries employ the primary TSH and backup T4 levels. So for hypothyroidism, it's mostly transient in, it usually causes transient effect in the newborns, and usually there's transplacental passage of maternal stimulating TSH receptor antibodies. The TSI receptor antibodies will activate the TSH receptor, and this leads to hypothyroidism. And usually these autoantibodies take approximately 1 to 3 months to clear from the neonate system, and that's why follow-up is usually for up to around 3 months. The other effects of hypothyroidism are these fetal and neonatal risk at stillbirth, hypothyroidism, hyperthyroidism. Hyperthyroidism, if it is the TSI, the stimulating autoantibodies that are being transferred. Hypothyroidism, if it is the thyrotropin blocking receptors that are being transferred. Then they also have low birth weight and IUGR. So how do we approach babies who are born to mothers who had Graves' disease? So you ask yourself, is this mother during pregnancy, during the second and third trimester, were the TSH receptor autoantibodies checked? Were they positive or are they unknown? So if they are positive, that is a high-risk neonate. That is a neonate who is more likely to have neonatal Graves' disease. So how will you go about that? You will, at birth, you ensure that you take cord blood and check the TSI receptor, the TSI autoantibodies. And if you find that the TRAB antibodies are positive, then at day 3 to day 5, you have to check the TFTs. And if you find that this baby has features of hyperthyroidism, that is confirmed biochemically, that is you have a depressed TSH and a high free T4, that is a baby you need to treat. You start them on methimazole or carbimazole. And then you need to follow them up at 2 weeks after delivery, and then thereafter monthly, at least for the first 3 months, when we expect the autoantibodies to clear from the system. Then if you have a mother whose maternal TSH receptor antibodies at the second and third trimester were negative, then that is a low risk newborn, and usually there's no specific follow-up that is needed. And then at every visit, you need to check whether they have clinical manifestations for Graves' disease, which is irritability, increased appetite, poor weight gain, tachycardia, etc. So for the ones who have biochemical hyperthyroidism, or clinically they have symptoms and their TSH is depressed with a high free T4, you start them on methimazole. Usually we give them at a dose of 0.2 to 0.5 milligrams per kg in 2 divided doses. And then you follow them bi-weekly for the next 2 to 3 months. And then for those from the screen, you find that have central or primary hypothyroidism, you need to repeat the free T4 and TSH level within 1 week, and then in case that is confirmed, you start them on the levothyroxine. So what is important in babies, what you need to take home from this is that it is good to do a proper clinical examination and a good history, a good maternal history, so that you can be able to know babies who are at risk of getting these conditions. So for our case, what happened is later on, a mother, remember this mother was reported to be okay during pregnancy. So maternal TFTs were done, and the TSH was depressed, had high free T3 and T4, and the TSI autoantibodies were also high for the mom and baby. And now this mom was diagnosed to have Graves' disease after delivery, and the mom was also started on treatment. Then on further follow-up, by the second month, the TFTs for the baby had normalized, and we discontinued treatment. So take home message: maternal thyroid disorders have an impact on fetal and neonatal outcomes. Proper screening and management of mothers with current or previous history of autoimmune thyroid disorders ensures better pregnancy outcomes. And newborns of mothers with thyroid disorders require close follow-up, at least for the first 3 months. And newborn screening for thyroid disorders should be encouraged. And we are hoping, as Pediatric Endocrine Society of Kenya, in collaboration with the endocrinologists that are here, we can push the narrative to have Kenya as one of the countries that screen these thyroid disorders in our newborns. Thank you.
Thank you, Dr. Saumo. And I think this talk has been very enlightening, and I'm told to only take 2 questions, burning questions. So anybody with a burning question?
Thank you for those great talks to all the speakers. My question will be to Dr. Madhura. Yes, we talk of short stature and the importance of height, we all know. But what are the effects of growth hormone besides helping with height?
Thank you for asking that very good questions. In the interest of time, I stuck to the clinical approach of short stature, but you rightly actually pointed out through your questions that growth hormone, in addition to increasing height, is important for the metabolic needs of the body, and it does give a good control of lipids as well as metabolism in general. So the children, you can see, for example, Prader-Willi children, they generally tend to have an underlying growth hormone deficiency as well, and their lipid control and their central obesity, it all goes haywire, and growth hormone therapy really helps with that as well, in addition to the height of these children. Thank you.
Can I add on that? I know we have adult endocrinologists, so children with growth hormone deficiency as adults should be continued on a low dose of growth hormone. Yeah, because it helps with the cardiac. Otherwise, these children can die, adults, die of cardiac arrest. Yeah, they need a small dose of growth hormone to maintain their metabolism. Because they don't, when we do the growth hormone stimulation test, these growth hormones are zero. They don't have any growth hormone. So they need to be supplemented. Thank you. Any other burning question?
Thank you for the excellent presentations. Just one question, because sometimes we're consulted also for the children for patients with thyroid disease. So do we measure TSH after the first week of delivery? And do all mothers with hyperthyroidism need to have the TSI antibody testing for their children, especially because we don't necessarily check for, in some centers, for the TSH antibodies? So 2 questions.
Okay, let me, where is Dr. Saumu?
Thank you for that question. The first question on whether we check TSH after the first week. We can actually check TSH from the 3rd day, from 3rd to 5th day. Remember from the graph that I showed that at birth, there's usually that surge in TSH, and then it starts normalizing from day 3 to day 5. So anywhere from day 3 to day 5, it is okay to check the TSH levels. And then the next question is on whether infants born to mothers with Graves' disease, whether they need to have their TSI levels checked routinely. And when the baby is born, they are symptomatic. They have features of hyperthyroidism. You can take cord blood on day 1 to check for the TSI receptor, the TSI autoantibodies. Thank you.
Yeah, TSI is the TSH receptor antibodies. We call it TRAP, thyroid stimulating antibodies. It's the same thing. Yeah, thank you so much. I think my time is up.
I'll invite the PIDS team to take some photos, please. So thank you so much to the pediatric team. So we'll move on to the next session, and I'm privileged to invite one of our other international faculty, who is none other than Dr. Julia Molefe, who is a consultant physician and endocrinologist at Princess Marina Hospital and Gaborone Diabetes Referral Clinic in Botswana, and she will be taking us through beta cell preservation. Welcome, Doc.
Thank you very much for the introduction, and I would like to thank Kenya Diabetes Study Group for having me give this talk this afternoon, and thank you for staying awake in advance. It's my first time in Mombasa, but my second time in Kenya, and since I arrived, I've been told I look Kenyan. And the only thing that gives me away is when I open my mouth and start to speak. Otherwise, I look just like all of you. So because of that, I have sought adoption. And from today, I am a Mushada's sister. So I'll be giving you a talk
entitled Time for Treatment Intensification in Type 2 Diabetes. These are my disclaimers and my disclosures, and at the end we expect to have the following outcomes. As the conference was going on, I kept saying, oh my, somebody's talking about my topic. What am I going to say? There's a resounding theme that's been going on during the course of the conference, and one of them is intensification, and the other is early combination therapy. And I'm also going to speak along that line. And this is my beautiful country, Botswana. Most of you have good safari, and you recognize that is an elephant. It's not a lion. And this is the Okavango Delta, one of the most beautiful places in the world, and it's been listed as World Heritage Site in 2014. So when you visit Botswana, which I hope you will do, please go to the Okavango Delta and see something that Kenya does not have. So, as beautiful as we are in Africa, we have a problem, and we have a diabetes problem. And this slide has been presented, and I'm not going to go into it. The fact is that diabetes prevalence is going to increase globally, and it's going to increase more so in Africa, with about 129% increase in diabetes by the year 2045. And of note in this slide is that Africa contributes very little in management of diabetes. And as of 2021, when the IDF compiled the atlas, Africa contributed to less than 1% of the global expenditure in diabetes. It just shows that we don't have the resources to manage diabetes. And what more resources do we have to manage complications that arise as a result of diabetes? I was listening to the talk on diabetic foot 2 days ago, and they were giving the cost analysis of managing somebody who developed diabetes-related foot complications, and things like amputations are very costly. So it is in our best interest to really manage these and prevent these complications, because we don't have the financial capacity to manage the complications. So unfortunately, earlier on, Dr. Roslyn presented data on the prevalence of complications in the West, in the Western world. Unfortunately, in Africa, it's even worse than it is in the West. This is a meta-analysis that was published just 2 years ago in the British Medical Journal. And it was a meta-analysis for African studies that were conducted or published between 2000 and 2020. And out of the 109 studies, they had come up with a participant of almost 64,000. And they looked at glycemic control as well as other parameters that are necessary in management of diabetes. And of note there is that HbA1c, that's the glycemic control, was hard hit, with barely 27% of the people reaching a target of HbA1c less than 7%, with the mean as high as 9%. And it's important to note that despite poor glycemic control, these people, only 30% of them were actually on insulin. And this is, I highlighted some studies that involved my beloved country and some that involved Kenya. And you can see that it's just a third of our population really reach a glycemic control. How about the burden of complications? In the same meta-analysis, you can see that I didn't see earlier in the West where you had more than 20% of the people having some form of microvascular complications. However, you can see peripheral neuropathy as high as, in some studies, 61%, and retinopathy as high as 51%. In this meta-analysis, there was poor documentation of macrovascular complications. So we cannot say, like Pumba and Timon, that Hakuna Matata, because Kuna Matata in Africa, and the Matata is the diabetes. So then we need to speak more about management of glycemic control in delaying as well as preventing the progression of diabetes. So one may ask, why is it that glycemic control is so suboptimal in sub-Saharan Africa? And lo and behold, there is a high prevalence of therapeutic and clinical inertia in our setting. There's a delay in initiating, delay in intensifying therapy when you need to, and also delay in de-intensifying therapy when one needs to intensify therapy, because hypoglycemia also, it is a risk factor for cardiovascular disease. So somebody who is having frequent hypoglycemic episodes, one needs to also de-intensify therapy. So these are some of the factors that contribute to therapeutic inertia, and they have been classified in 3 levels: is the healthcare provider level, the patient level, as well as the healthcare system level. I'm not sure what situation Kenya has, but we have a serious shortage of human resources as far as specialized care is concerned. We have 4 endocrinologists in the whole of Botswana, and out of the 4, I'm the only one who is serving the public sector. The other 3 are in private. So you can see how limited we are in our country. It's good to come to a conference like this and you see so many, maybe not so many, but a little bit more than Botswana, so I am encouraged. And of course, we also have healthcare systems that are seen in other African countries, which also makes an issue of the choice of therapy that is appropriate for the patient limiting. But in all this, we still need to move on, because I said it is time, but I think we are behind time in early treatment intensification in the management of diabetes. I will not dwell on this because you have already been told about the benefits of lowering HbA1c as early on, and what are some of the benefits you get when you lower HbA1c just by 1%. But what about the consequences of delayed treatment intensification? On the lower aspect of the line is the patients who had early intensification, and the upper one is those who had delayed intensification despite the HbA1c more than 7% within a year of diagnosis. And look what happens. They have such high increased risk of myocardial infarction as high as 67%, and heart failure 64%, stroke 51%, just by 1 year, having an HbA1c that is above 7%. So this then comes to the issue of legacy. And legacy was first described in the UK PDS. We all know about it, or we have heard about it so many times in the conference, where they followed up patients after they have stopped the trial. They followed up the patients for a longer duration, up to 10 years. And the people who, the participants who were on the intensive therapy continued to have benefits, and they did not develop complications compared to the ones who were on standard of care, who developed microvascular complications. So this is what we call good legacy. You treat the patient, you intensify early, even though at some point they do not have good glycemic control. That good legacy that we had at the beginning of the disease is carried on, and the benefit is carried on. However, those who had bad legacy is the ones who then are diagnosed with diabetes. You do not treat them early on to intensify therapy to reach therapeutic targets sooner. And now we are talking about within 1 year of diagnosis. So even at some point, you and the patient come together and you say, you know what, we need to fight this thing. The duration of glycemic exposure to the person and to the cells has already been done. So even if you control at some point, that damage is already done. You will get some benefit a bit, but not as much as you had controlled early on. So that's the bad legacy. So in intensification, there are some principles that one needs to know about. And now, as doctors, we need to move away from prescriptive medicine and giving orders to our patients and like a dictatorship sort of thing. Mama, you have got diabetes. From today, I'm going to give you insulin and glimepiride, or I'm going to give you metformin and glimepiride, and then I'll see you again in 3 months. That's not how you manage patients with diabetes, because the cornerstone of diabetes management is self-directed. And somebody to direct their therapy, you're going to prescribe exercise, you're going to prescribe diet. The patient should be on board with the management plan. So we spoke about language or communication with patients so that patients are part of the informed decision making to support or to adhere or to be compliant to the treatment plan. And then the treatment must be what? Individualized. And then weight has now become very important in the management of diabetes. In fact, the guidelines recommend that when you prescribe medications for diabetes, you must consider the weight of the patient, because obesity itself is one that contributes to most of the pathophysiologic bases that cause diabetes and even progression of beta cell loss. So the target weight loss of 10 to 15% by any means, even including the bariatric surgery that our gastroenterology was talking about, has been shown to cause a remission. And some have gone into remission purely by intensive exercise. And then, of course, glucose monitoring and avoidance of therapeutic inertia. So what are some of the things you consider? You want to consider the goals of glycemic control, because it differs. Mostly it's less than 7%, but there are some you want to give them 8%. Maybe they are frail, they are elderly, and they are at risk of hypoglycemia, or they have got a shorter lifespan. And then you want to consider the risk of hypoglycemia as well as weight goals for the patient. And you look at the patient in front of you. Do they have cardiovascular disease? Do they have kidney disease? What about liver disease or other comorbidities? And of course, in Africa, we cannot forget about social determinant of health and complications. So this slide was presented many times. I'm just going to say that this is the American Diabetes Association and the European Association of the Study of Diabetes statement of 2022. And they say patient must be at the center of therapy, and there must be a holistic approach to the management of diabetes. And your goal is to maintain glycemia, but also improve the quality of life of the patient. So there is glycemic management, there is weight management, and on the yellow you have got cardiovascular risk management. Sometimes we tend to forget that patients with diabetes are actually high-risk cardiovascular patients, and they need to be categorized as that and treated as such. So the blood pressure target should be less than 130/80, and then you must also consider lipid lowering. 40 years to 75 years, they must be on a moderate intensity statin with a target LDL cholesterol of at least 50% or less than 1.8. And if they have had a atherosclerotic cardiovascular disease, the LDL should go to less than 1.4. And then, of course, if there are other things. And then this has been spoken about regarding kidney and stuff. I won't go into it. I want to talk about the decision making for the patient. You need to talk to the patient, assess, consider all the other things that we considered, come up with a plan, and then you set up goals and objectives with your patient. And then the objectives, just like any in research, they must be SMART. Means they should be specific, it should be measurable, something that you can come back to and say, look, we didn't achieve. You come up with a management plan, and then you install the plan, and then you review the cycle. And then when you see the patient, you discuss this. And then we are going to talk about early combination that can be considered as a treatment initiation to attain glycemic goals. And these are some of the glycemic goals that you know about. I've spoken about it, and these are some of the drugs that we use. In Botswana, we have almost all of this, and for DPP4 inhibitors, we use mostly vildagliptin and sitagliptin. And then, of course, we have our injectables that have been presented. And there's the new kid on the block is the tirzepatide, which Prof spoke about. And it sounds like he's taking diabetes management by storm. But for us, it can only be a dream in Africa. We will never be able to afford it anytime soon or in the near future. So we'll have to work with whatever we have. So type 2 diabetes involves both pathophysiology, involves resistance as well as some form of insulin deficiency. And it is a progressive disease. And in actual fact, by the time a patient with type 2 diabetes is diagnosed, they've had diabetes for quite some time, or dysglycemia for quite some time, and some of them have even lost 50% of their beta cell. And also it's important to note that some can already develop, come with complications. Those are the face of the diseases to tell you which drug can work when you have type 2 diabetes. So what are the causes of beta cell decline in people with diabetes? Cornerstone of diabetes cause is insulin resistance and obesity. You have decreased insulin secretion, eventually beta cell work overload, you develop diabetes. And then the hyperglycemia, if it's not managed, it causes a vicious cycle. And one need to know is that glucose itself, hyperglycemia, is glucotoxic. And if you have obesity on top of that, you've got free fatty acids around, and then insulin resistance as well as obesity are a stage of chronic inflammation with a lot of oxidative stress, mitochondrial dysfunction, and then also they have this amyloid deposition because of disordered insulin synthesis. So these are some of the things that cause beta cell decline. And you will realize that some things that cause beta cell decline are actually pathophysiologic in the cause of diabetes. Now we're speaking of egregious 11 of type 2 diabetes, which start, of course, number one, in the pancreas with pancreatic dysfunction, insulin resistance, and then also there's decreased incretin effect. There's also increased glucagon because alpha cells are also not functioning well, and of course, insulin resistance at different levels. So we have some drugs that actually target this egregious 11 of type 2 diabetes. And GLP-1 receptor agonists have been shown to have multifactorial effects that work together to reduce hyperglycemia. And of note there, just the pancreas, is that a GLP-1 receptor agonists actually prevent beta cell apoptosis. They actually also increase beta cell formation and increase insulin biosynthesis. They are expensive in our setting, and also because they are injectables, patients don't really like to take them. But we do have DPP4 inhibitors. The body produces its own GLP-1. The only problem is that it gets deactivated so quickly by an enzyme called dipeptidyl peptidase 4. So if you were to inhibit this dipeptidyl peptidase 4 enzyme, you're going to have a higher concentration and even a longer duration of action of the GLP endogenous. And then you are going to have these benefits. So wherever the GLP-1 is, the DPP4 inhibitor also is. So we can tackle the egregious 11 by GLP-1 as well as DPP4 inhibitors. So DPP4 inhibitors will influence both insulin resistance as well as pancreatic islet dysfunction. In fact, also another meta-analysis to look at the level of beta cell preservation by different drugs. DPP4 just was only inferior to GLP-1 receptor agonist and was found to be superior in beta cell preservation to SGLT2 inhibitors and alpha-glucosidase inhibitors. And now I want to talk about early combination therapy in type 2 management with focus on a verified study. This study, I decided to talk about it because it's the study that changed guidelines. It spoke to treatment guidelines, bodies to change their way of thinking from the traditional stepwise of adding add-on to early combination. So the problem then that if I wanted to address was really the problem of therapeutic inertia. To show that therapeutic inertia, you start, then you, at one point, the zigzag is sequential addition of medications. And then this is designed for the verify. It was a randomized control study, which was double-blinded, meaning that both the investigators and the participant did not know what they were randomized to. But they were randomized to either metformin and vildagliptin to start with, and then they also, the other ones were randomized to metformin and placebo. And then their primary endpoint there was treatment failure, which was defined by HbA1c that was more than 7% on 2 consecutive visits, which were 3 months apart. They also had secondary analysis. And this is the inclusion criteria. You might say that, I don't know what you see, but we see quite very high diagnosis, some high as 12, 14, some even beyond the lab measurements in people with type 2. So these were quite controlled, to say. And of note also is that only South Africa was represented in this population, making a black population of only 2.6%. But this is not different from a lot of NCD clinical trials. We only really get represented mostly in infectious trials. These are some of the parameters at baseline and primary analysis. The olive green there is the initial monotherapy and the blue is the early combination. You can see that there was a statistical significant decrease in the time to treatment failure compared for those with early combination compared to the initial monotherapy. And they couldn't even, they could only estimate beyond the end of the trial because the trial lasted for 5 years. So they could estimate that initial treatment failure was up to 69.9 months, whereas in initial monotherapy was at 36 months. And then the secondary analysis as well, this was secondary failure. They also showed that there was a statistical significant difference in the time it took from early combination compared to initial monotherapy. And then this was some of the things that they looked at, and the blue is still early combination, and then the lime green is initial monotherapy. So you can see that the proportion of patients who had HbA1c less than 7% was quite significant with early combination. So what does Verify tell us? With having combined therapy at the beginning of pharmacologic treatment in patients with diabetes, it's possible. And of note is that they combined 2 drugs that have complementary mechanisms of action. Metformin increases insulin sensitivity, whereas DPP-4 inhibitors will actually increase insulin secretion, among other functions. So, and of note is that there was also low risk of hypoglycemia, and it's important now with the weight at the center, there was no significant weight gain. So one may say at this point, maybe we should start moving towards combination therapy with the aim of reducing clinical inertia in our patients. Like I said, guidelines have now changed. This is the ADA and ESD. Since 2021, they have recommended early combination therapy in people with type 2 diabetes, and they quoted Verify as their guiding trial to do this. And now recommendation is that anybody who have HbA1c that is at least 1.5 above the goal, they should be started on combination therapy. So one might say, because I said the cases that they saw, the participant didn't have quite high HbA1cs. So what about clinical practice? In Botswana, we are able to get DPP4 inhibitors in the public, and also the combination therapy they were able to get to our patients. So I will just present 2 cases that we saw in the public sector of Botswana. The first one was a Miss FM. She's got a background of hypertension, no target organ damage. She presented to our clinic with classic symptoms of hyperglycemia, and she has obesity, and her HbA1c diagnosis was more than 14%. So issues, she's got metabolic phenotype with abdominal obesity, and she has got very high HbA1c diagnosis. So ideally, this person should be a candidate for insulin therapy at diagnosis, but she is unwilling, and she's young, she doesn't want to gain weight. So we had a discussion, and she promised to exercise and eat according to what we prescribe, which they usually never do. And then we started her on metformin and vildagliptin. It wasn't a combination therapy, a combination in one drug, but it was 2 separate drugs, 2 separate molecules. And then we reviewed her 3 months later, and the HbA1c has dropped to 9%, which is very impressive. And then the other patient was a gentleman, diagnosed type 2 diabetes last year, March, and HbA1c diagnosis was 11.9%. He was also overweight with a BMI of 28.6. We also started the patient on metformin and vildagliptin, and this time around, the person who saw also put a sulfonylurea. At 3 months review, this person has their HbA1c up to 6.7%. And a year later, the HbA1c was 7.9. So this patient now needs more intensification to lower the HbA1c. So, but having said that, as much as patients fear insulin, and you also want to, because of its weight issues, type 2 diabetes is a progressive disease, and eventually many people, to intensify further, will require, some will even benefit from insulin. But however, if one could afford, if you were to choose between insulin or an injectable to optimize care, guidelines recommend to choose either a GLP-1 receptor agonist or a dual GIP and GLP-1 receptor agonist prior to initiating insulin. So this has been said that, to be honest, insulin was the best medication for diabetes until the tirzepatide trials. So we've seen now that tirzepatide can actually drop glycemic control better than, in some instances, better than insulin. So when insulin is indicated, please give it. And these are some of the indications for insulin. So in conclusion, management of diabetes is complex, and the approach should be individualized, and one must have weight considerations at the center. And many people with type 2 diabetes fail to achieve glycemic targets for various reasons, one of which includes therapeutic and clinical initiation. Pharmacologic therapy should be guided by person-centered treatment factors, and one should also consider comorbidities such as cardiovascular disease, kidney disease, and obesity. And one should set treatment goals with the patient. And then early combination therapy can be considered in adults with type 2 diabetes, and treatment initiation to shorten time to attainment of individualized treatment goals. And treatment modification, either intensification or de-intensification for adults not meeting target, should be done so in timely manner to achieve treatment goals. Thank you very much for your attention.
So thank you so much, Dr. Julia, for that wonderful talk. We have just time for one question, please. Bunning.
Thank you very much, Doc. You're very eloquent, and I liked the way you delivered the presentation. We've really enjoyed it. Mine is a comment. I like the way you've introduced the aspect of early intensification and titration of medications. Mine is just to put a point across and to clear the air. Yesterday I had a presentation about insulin, and I think one of the issues that came up from it is that some people came out with information that maybe was not quite the correct information that we were trying to give, that insulin is not effective and it is a killer, so to speak. So I'm just trying to clear the air to say insulin is one of the, it's actually the most effective diabetes drug. But at the same time, there are still certain side effects that can come, as with any other drug, like weight gain, and there are studies that have shown there could be possible mitogenic factors, etc. So that's what we were trying to bring out yesterday, rather than just doing an insulin intensification and titration seminar, which we have been doing all along. It was bringing a new aspect to insulin to try and make us realize that indeed there could be other factors associated with insulin use. So I just wanted people to not go away from this conference thinking that insulin is a dangerous drug. Insulin is a life-saving drug. We just want to explore more about the use of insulin and also read and study and do more research so that we can understand how the drugs that we give, exogenous insulin, the drugs that we give, how they affect the body in our patients. That was just trying to clear the air so that people don't come out of here with a bit of confusion. But back to your presentation, Daktari, I think you did it quite well, and we appreciate you.
Thank you once again for paying attention, and I am sorry to keep you longer for before lunch.
Just one comment, Daktari, there's something you've mentioned when you were talking about the GLP-1s, tirzepatide, you said that this is not going to happen. Let me take you back. You had metformin, then you had the sulfonylureas, right? And then because you started prescribing your DPP-4s, which were unattainable, we've made it attainable. So what we practice in Kenya is, if you know that the drug has benefits, start prescribing. That actually influences the cost. And so now we are having combination therapies of your metformin and your DPP-4s. We have started using the GLP-1 analogs, and I think sometimes we shy away from giving certain drugs to patients, and maybe they can afford. So you may not have such a big sample, but now this is a challenge to you in Botswana and for the rest of Africa. Don't deprive a patient of a medication just because of the cost. Perhaps they can afford, even if you can't. Majority of us cannot afford these drugs, but our patients can. And we can be the drivers of how we can be able to control even the prices in the market by just simply prescribing supply and demand. Just a challenge.
No, I think, thank you so much, Roslyn, for the comment. Yeah, it's very true. I think even the GLP-1 receptor agonists in Botswana, I think Botswana system is a little bit different from Kenya's medical healthcare system, in the sense that medical care in the public sector is free. So you don't pay for medications and procedures. So the government pays for these kind of medications. So they pay freely for DPP-4 inhibitors. However, with the GLP-1 receptor agonists, we really have to motivate it. However, in private, one can freely prescribe. I do part-time private. I can prescribe GLP-1 receptor agonists, but in the public, it's a problem. But I want to agree with you that when one prescribes, because even to move a medication from sort of special patient-to-patient order to putting it in the essential drug list, the government want to see how often the drug is being prescribed for patient. Then it can actually be included in the essential drug list. And once it's in the essential drug list, it becomes freely accessible to even patients in public. So yes, it's a dream that we can also have all these high quality medications for our patients, really.
Thank you. I'd like to invite, Doc, please don't go, for photos, Prof, Eric, and Rosaline. All right, thank you. Let's give her a hand, please. So we'll break for lunch. Please don't forget to pick up your vouchers as you exit. We will be back promptly at 2:40 for a start. So please, guys, don't delay at the stands. Come back by 2:40 so that we can get through the afternoon program.